Hello guys! My name is Brian Dais, a student nurse of Visayas State University, and today you are watching Chronic Obstructive Pulmonary Disease or COPD, as well as its two types, which is chronic bronchitis and emphysema. The goal of our video is for you to be able to trace their pathophysiology, identify their clinical manifestation, and how to diagnose COPD, as well as their treatment and management. Let us talk about COPD. So what is COPD? COPD is a disease that is treatable and preventable, but it is a respiratory disease that slowly progresses as we grow old, or they are very slow in terms of progression. So it is a problem within the airway because of there is obstruction, or there is problem within the pulmonary parenchyma, or both. Now, let's talk about the risk factors o yung mga contributing factors kung bakit nagkakaroon ng COPD ang isang tao. Una, smoking. So, about 95% of our COPD patients are heavy smoker. Another reason is the constant exposure to contaminated air. So, yung mga COPD patient din natin na iba na hindi heavy smoker ay nagkaka-COPD dahil nagtrabaho sila sa mga factory na kadalasan na-expose sila sa mga harmful chemicals. Another is genetics. Ito yung may mga autosomal dominant disease o yung meron silang problem, two defective copies. So, kakaroon sila ng kaunti or walang napoproduce yung liver nila ng alpha-1 antitrypsin. So, mamaya pag-usapan natin kung ano yung function ng alpha-1 antitrypsin at kung bakit nagiging factor ito sa COPD. Another is advanced age. So, alam naman natin po na pag tumatanda tayo, yung normal na respiratory function natin ay bumababa. Hindi katulad ng bata pa tayo hanggang mga around mga teenager hanggang mga middle age. So, another is infection. Pwede kakaroon ng COPD or because palagi silang kakameron ng mga infections. So minsan kadalasan secondary yung COPD such as chronic bronchitis or yung emphysema. So malalaman natin kung bakit anong role ng infections sa COPD. Now, let's talk about chronic bronchitis. So what is chronic bronchitis? It is a disease of the airways and is defined as the presence of cough and sputum production for at least 3 months in each of the 2 consecutive years. Yung overproduction ng mucus, yan talaga yung mga hallmark ng chronic bronchitis. Ngayon, makikita nyo sa picture yung difference ng normal na bronchial tube at ang inflamed na bronchial tube. Now, take note po, normal lang na may mucus ang airways natin. Kasi nga, ang function nila is to humidify and moisten the air coming in and trap certain pathogens or pollutants. Ang problem po sa chronic bronchitis ay sobra yung amount ng mucus na napoproduce nila. Usually because of irritants, smoking, or pathogens. Yung overproduction ng mucus ay ang nagiging cause ng narrowing ng airways natin. One of the big things we have to remember, there will be a hypertrophy and hyperplasia of the mucinous glands. There are also other cells that are important in the mucus production, and that is the goblet cells. Yung mucus na napoproduce nila ay same pa rin sa function ng mucus na meron na napoproduce ang mucus glands. And that is to humidify and moisten the air, engulf irritants and pathogens. Ngayon, if there is so much irritation, especially caused by smoking, it may affect our cilia. Pwede lumiit yung haba ng cilia at maging less motile ito. At pang nangyari yun, there will be an accumulation of mucus in the airways. Mahihirapan na mailabas yung mucus sa katawan natin. Ito na yung tinatawag nating ciliary dysfunction, na overcome na yung function ng cilia, and that is to propel mucus. Now, if there is overproduction of mucus, and our cilia is not properly functioning, magkakaroon ng mucus buildup, and it may plug the airways. Now imagine if there's a plug in the airways. Mahihirapan pumasok ang oxygen papuntang alveoli, and at the same time mailabas ang carbon dioxide sa katawan natin. Magkakaroon na ng tinatawag nating air trapping. At dahil hirap na makapasok ang oxygen papuntang alveoli at mailabas ang carbon dioxide, magiging cause na ito ng tinatawag nating hypoxemia at ang hypercapnia. Ang hypoxemia po ay ito po yung low in partial oxygen sa katawan natin, at ang hypercapnia ay ang excessive or yung mataas na amount ng carbon dioxide sa katawan natin. At dahil nga po sa mucus buildup sa airways natin, magiging ideal po ito ng bacterial growth. So yung mga taong may mga chronic bronchitis ay at risk po sila na magka-develop ng pneumonia. Now, let's move on to emphysema. Emphysema, it is a pathologic term that describes an abnormal distension of the air spaces beyond the terminal bronchioles and destruction of the walls of the alveoli. Take note po, kapag emphysema, ito po ay structural issue, while yung chronic bronchitis ay overproduction ng mucus. Now with emphysema, what happened is, these factors, environmental factors, smoking, the pollutants, and the alpha-1 antitrypsin deficiency can all lead to this condition. Now let's focus first on these environmental factors and smoking. Let's say there is a microorganism that or a pollutant that entered the alveoli. Now what happened is the alveolar macrophages will engulf this microorganism or pollutant. It will undergo the process we called phagocytosis. As they engulf this microorganism, the next thing that they will do is to produce cytokines. These chemicals will help in the activation of neutrophils. It is like calling the attention of many neutrophils. Once these neutrophils are activated, these neutrophils and macrophages will begin to produce specific enzymes. These enzymes are called protease. There will be a lot of enzymes that they will produce, but the protease that I want you to remember is the elastase. Ngayon, parang nagkaka-idea kayo kung ano yung elastase. Yung elastase, they break down elastin, which is a connective tissue. Let's have a little recap on the function of elastin. Importante po malaman natin yung function ng elastin. They are responsible to the recoil of lungs. Whenever we inspire, our accessory muscle, the diaphragm, the intercostal muscles, and because of that, they will expand. They will expand energy. But that is part of the whole process of inspiration. It is an active process. So expiration normally is a passive process. Whenever our lungs reach its full capacity, the elastic tissue is designed to draw lungs back to its normal size. Now, if you lose that elastic recoil, now what your lungs gonna do? They can expand easily, but they're not gonna be able to recoil and push a lot of air out. And what that cause is air trapping. Aside from elastic recoil, another thing, elastin helps in keeping the airway open. So remember, whenever we exhale, our respiratory airways are getting smaller. But our elastic tissue helps keeping that airway open by creating an opposite force. This opposite force is called Bernoulli Principle. It is spelled as BERNOULLI. So in the Bernoulli Principle, it says that air leaves in a high velocity, creating a negative pressure. So we need an elastic tissue to pull on the opposite direction to keep the airway open. But if you lose that elastic tissue, you will lose that opposing force. Now, because the pressure is so low, it may collapse. and may contribute to air trapping. Now, let's talk about how alpha-1 antitrypsin deficiency can contribute or cause emphysema. Our liver releases a specific protein in the blood called alpha-1 antitrypsin. Now, what does this protein do? Its job is to inhibit elastase. So kung walang elastase, walang breaking down ng elastin. Pero kapag ang tao ay may problem sa liver or may mga autosomal dominant disorder, means meron silang dalawang defective copies. Ngayon, yung liver mo ay hindi makaproduce ng antitrypsin o mag-produce man, nasa maliit lang na amount. So kung mangyari yun, sino pa mag-stop ng elastase? Di ba wala? So makukontinue ang breakdown ng elastin kasi na-overcome na yung amount ng elastase ng alpha-1 antitrypsin. Wala na mag-stop ng elastase. Ngayon, kung wala ng elastin o yung elastic tissue, mawawala din yung opposing force and it may cause to collapse and air trapping. And over time, because of the accumulation of air in the sinus, it may result in the disruption of the surface area of the alveoli. Not only you lose that elastic tissue, but also the breaking down of alveolar septa. Now, instead of many alveoli surface area, it begin to create a big balloon of air. Now, there are three types of emphysema, depending on the location where they lose that alveolar surface area. Una, yung centrilobular emphysema o centriacinar emphysema. Nasa gitna sila tumubo. Yung sumunod naman ay ang panlobular or panacinar emphysema, which is nasa gitna at distal part sila tumubo. At ang panlas ay ang parasepto. Nasa distal part sila ng lungs tumubo. At itong last na ito ay maaring mag-cause ng pneumothorax because as they reach their full capacity, they may rupture and it may cause to the leakage of air and causing lung collapse. Let's talk about their clinical manifestation. Chronic bronchitis are also called as blue bloaters because they are commonly found in patients who are obese. Another is cyanosis. This is because of low oxygen entering the alveoli. There is poor gas exchange. Another is there is a productive cough for a long period of time, wheezing on expiration, truckles on inspiration, an increase in AP diameter, hyperresonance during percussion, and dyspnea on exertion. Now let's move on to emphysema. Emphysema is also called as pink puffers. What are the common signs that you may notice to patients who have emphysema? One is pursed lip breathing and prolonged expiration. These are mechanisms to compensate the air buildup in the lungs. Another is during the early stage of emphysema, you can notice that the patient is properly oxygenated. They are well perfused. While on the later stage, they may be cyanotic. Another signs and symptoms that we can observe to patients who are suffering from emphysema is weight loss, wheezing on expiration, an increase in AP diameter, and hyperresonance during percussion. How do we diagnose COPD? First is through clinical diagnosis. We are going to assess their health history, whether they had a previous respiratory infections. Are they active smokers? What kind of jobs that they do have? Or they do have an underlying liver disorders. And during examinations, prominent signs such as barrel chest can be observed. Another is the PFT, or the Pulmonary Function Test, which is the gold standard in diagnosing COPD. We are going to assess their lung volumes and lung capacity. specifically on FEV1, or the forced expiratory volume in 1 second, and FVC, or the forced vital capacity. After determining this data, we will going to divide it. And if the result is less than 75%, it is positive for COPD. It can be asthma, or emphysema, or chronic bronchitis. But one thing to ensure if it is emphysema or chronic bronchitis, we're going to give the patient a Another test that we can conduct is pulse oximetry. We will check if there is a decrease in oxygen saturation level. An O2 less than 88% is the patient is advised to have a supplemental oxygen. Another test that we can conduct is ABG, or arterial blood gas. The things that we are going to see is that there is an increase of partial carbon dioxide, a decrease of partial oxygen, and decreased blood pH, which we can conclude that there is a pulmonary acidosis. We can further conduct tests such as EKG or electrocardiogram. We're going to rule out MI or CHF. A patient who have COPD may show multifocal atrial tachycardia or MATS. Another is that there will be a right ventricular strain. Another possible test that we can conduct is chest X-ray or high-resolution CT scan. We can check if there is an air trapping, hyperinflation of the lungs, and flattened diaphragm. Now, let's move on to the treatment of COPD. First is smoking cessation, since most of COPD cases are caused by heavy smoking. Another is an updated shot on vaccines, especially on influenza vaccines and pneumococcal vaccines. Another is if the patient is suffering from low oxygen, we will give an supplemental oxygenation. We also give bronchodilators, anticholinergic, and beta-2 agonist. If the patient has an acute exacerbation of COPD, an IV or oral steroid is given, but not usually since steroids has a lot of side effects. An inhaled corticosteroids is given adjunct to LABA. These are for severe cases. We also give phosphodiesterase inhibitors, such as theophylline. We give it to patients who have a severe case, allowing the diaphragm to rest. Surgical interventions such as bolectomy, lung volume reduction surgery, and lung transplantation. Now, let's move on to nursing management. So first, we are going to assess our patient by conducting physical examination and taking health history. One of the goals that we can set in our nursing management is to achieve airway clearance. We can monitor the patient for dyspnea and hypoxemia. Administer bronchodilators or corticosteroids if prescribed. Instruct patient for direct coughing. Chest physiotherapy with drainage. Increase oral fluid intake. Another goal that we can set in our nursing management is to improve their breathing patterns through inspiratory muscle training and breathing retraining and pursed lip breathing. Another goal is to improve their activity tolerance by introducing them to rehabilitation therapies, occupational therapies, and physical therapies. And last nursing management is to monitor our patient and to manage potential complications. Okay guys, again, this is Brian Dais. I hope you learned a lot from this video. And don't forget to try to comment if you have questions, and I'll try to answer each one of them. And please read a lot for more resources, because what you've seen in this video is only a simplified form of the concept of COPD. So thank you again for watching. How do we diagnose COPD? First is through clinical diagnosis. We are going to assess their health history, whether they had a previous respiratory infections. Are they active smokers? What kind of jobs that they do have? Or they do have an underlying liver disorders. And during examinations, prominent signs such as barrel chest can be observed. Another is the PFT, or the Pulmonary Function Test, which is the gold standard in diagnosing COPD. We are going to assess their lung volumes and lung capacity, specifically on FEV1, or the forced expiratory volume in 1 second, and FVC, or the forced vital capacity. After determining this data, we will going to divide it. And if the result is less than 75%, it is positive for COPD. It can be asthma, or emphysema, or chronic bronchitis. But one thing to ensure if it is emphysema or chronic bronchitis, we're going to give the patient a bronchodilator. And if there is no significant increase beyond 12%, then it is positive for emphysema and chronic bronchitis. Now, if there is overproduction of mucus and our cilia is not properly functioning, magkakaroon ng mucus buildup and it may plug the airways. Now imagine if there is a plug in the airways. Mahihirapan pumasok ang oxygen papuntang alveoli. And at the same time, mailabas ang carbon dioxide sa katawan natin. Magkakaroon na ng tinatawag nating air trapping. At dahil hirap na makapasok ang oxygen papuntang alveoli at mailabas ang carbon dioxide, magiging cause na ito ng tinatawag nating hypoxemia at ang hypercapnia. Ang hypoxemia po ay ito po yung low in partial oxygen sa katawan natin at ang hypercapnia ay ang excessive or yung mataas na amount ng carbon dioxide sa katawan natin. Now, let's talk about chronic bronchitis. So what is chronic bronchitis? It is a disease of the airways and is defined as the presence of cough and sputum production for at least 3 months in each of the 2 consecutive years. Yung overproduction ng mucus, yan talaga yung mga hallmark ng chronic bronchitis. Ngayon, makikita nyo sa picture yung difference ng normal na bronchial tube at ang inflamed na bronchial tube. Now, take note po, normal lang na may mucus ang airways natin. Kasi nga, ang function nila is to humidify and moisten the air coming in and trap certain pathogens or pollutants. Ang problem po sa chronic bronchitis ay sobra yung amount ng mucus na napoproduce nila. Usually because of irritants, smoking, or pathogens. Yung overproduction ng mucus ay ang nagiging cause ng narrowing ng airways natin. One of the big things we have to remember, there will be a hypertrophy and hyperplasia of the mucinous glands. There are also other cells that are important in the mucus production, and that is the goblet cells. Yung mucus na napoproduce nila ay same pa rin sa function ng mucus na meron na napoproduce ang mucus glands. And that is to humidify and moisten the air, engulf irritants and pathogens. Ngayon, if there is so much irritation, especially caused by smoking, it may affect our cilia. Pwede lumiit yung haba ng cilia at maging less motile ito. At pang nangyari yun, there will be an accumulation of mucus in the airways. Mahihirapan na mailabas yung mucus sa katawan natin. Ito na yung tinatawag nating ciliary dysfunction. Na-overcome na yung function ng cilia, and that is to propel mucus. At dahil nga po sa mucus buildup sa airways natin, magiging ideal po ito ng bacterial growth. So yung mga taong may mga chronic bronchitis ay at risk po sila na magka-develop ng pneumonia.